Then the front of the thigh. In the front of the thigh, we have seen that the front of the thigh is covered by the first layer of the body, that is the skin. And when we cut the skin after dissection from the front of the thigh, we see the superficial fascia, which consists of the everywhere yellow color fat held by the loose areolar tissue. And in this loose areolar tissue, we find the cutaneous structures, the cutaneous artery, veins, nerves, lymphatics, and lymph nodes. The most prominent thing in the superficial fascia of the front of thigh is the great saphenous vein, which lies parallel to the medial border of the thigh, and various superficial veins going to their areas, accompanied by the superficial arteries, and there was T-shaped arrangement of the lymph nodes. One is the horizontal group. They are the superficial group of the lymph nodes, bringing the lymphatics from the lower abdomen. They are all interconnected. Another group was along the vertical group, along the great saphenous vein. So they are all interconnected. So they are the superficial group of the lymph nodes in the superficial fascia of the front of the thigh. Then we also encounter here in the three nerves. One is the medial cutaneous nerve of the thigh, then the intermediate cutaneous nerve of the thigh, and the lateral cutaneous nerve of thigh. So this is the picture of the superficial dissection. So when we remove this whole of the superficial structures in the front of the thigh, we encounter the third part of the human body, and that is the deep fascia. As we have seen, that deep fascia is circumferential arrangement is there, attachment in the upper part to the every part here, and it is attached to the anterior spherical spine and the inguinal ligament superiorly along this border. Then the attached to the pubic tubercle, pubic symphysis, ischiopubic ramus, and laterally it was thickened to form the iliotibial tract. So everywhere there is a deep fascia, except 4 cm below and lateral to the pubic tubercle. There is an oval opening is left here, that is called the saphenous opening. And inferiorly, the deep fascia is attached to the medial and lateral condyles of the femur below. So this deep fascia gives the shape to the thigh, plus it protects the deeper structures, that is the bone, muscles supplied by big arteries, veins. So this is the deep fascia, that is called the fascia lata. When we remove this deep fascia, we encounter the fourth layer of the human body, that is the muscles. So muscles we have done, so they are the three groups of the muscles: medial, intermediate, and the lateral group of the muscle. Their origin, insertion, action, and their nerve supply also. The muscles of the front of the thigh. So this was the pelvic bone, and here lies the acetabulum, the cup of the hip joint, which articulates with the head of the femur to form hip joint. This is the greater trochanter, neck. This is lesser trochanter and intertrochanteric line joining them. This was the medial border of the femur with the adductor tubercle and medial condyle, and this was the lateral condyle of the femur. This is the patellar surface of the femur. Below it articulates to form the knee joint with the lateral and medial condyle of the upper end of the tibia with tibial tuberosity, and this is the shaft of the tibia. Lateral bone is the fibula, attached to here. And there was a kneecap or the patella articulated with the patellar surface, large lateral and small medial part. So we have done various muscles. From the medial part, this is the gracilis, the medialmost muscle origin. This was the psoas major, between the angle between the pubic crest and the pubic symphysis. Then there was adductor magnus taking origin from the body of pubis, ischiopubic ramus up to the ischiotuberosity, and the uppermost fibers of the adductor magnus, they are inserted over the linea aspera or posterior border of the femur. The lowermost fibers, they descend to the adductor tubercle, leaving a small opening that is called the hiatus magnus. So this was the fan-shaped magnified adductor magnus muscle lying posteriormost in the adductor compartment, and there are present 4 more small openings in the aponeurotic tendon at the insertion on the linea aspera. They are called the osseo-aponeurotic openings. And then there was a adductor brevis muscle taking origin from the body of the pubis in the front part, and it is inserted over the linea aspera in the upper part. Then the adductor longus muscle also inserted on the posterior border or linea aspera of the femur, and the gracilis is the medialmost muscle of the thigh, coming medially, vertically downward, and inserted over the upper shaft of the tibia, just medial to the sartorius insertion. And the obturator membrane was closed by the obturator membrane, except superolaterally there was a small hole, that is the left in the obturator foramen, that is the obturator canal, through which the obturator nerve comes, with anterior division supplying the adductor brevis, adductor longus, and gracilis muscle. Plus it also gives a branch, that is the intermediate cutaneous nerve with height. Then the posterior branch pierces the obturator externus muscle and runs posterior to the brevis and longus muscle and supplies the adductor magnus, plus obturator externus muscle, the posterior branch. And it also gives a cutaneous branch, that is the medial cutaneous nerve of thigh. And it is accompanied by the obturator artery and obturator vein also in the obturator canal. Then there was the intermediate compartment of the front of the thigh, and the pecten pubis, a muscle is taking origin, that is called the pectineus, and this pectineus muscle is inserted over the upper 5 cm of the shaft of the femur. So this is the pectineus muscle. This is the medial border, this is the lateral border. So medial border receives a branch from the obturator nerve. The medial half is supplied by the obturator nerve. Then from the abdomen, posterior abdominal wall, comes a muscle, that is the psoas major muscle, taken from the intervertebral disc of the T12, L1, L2, and this muscle comes with the tendon below the bridge, that is formed by the inguinal ligament. So it passes below the inguinal ligament, the tendon comes for insertion into the thigh and inserted over the posterior surface of the lesser trochanter. So this was the psoas major. From its medial border arises the obturator nerve in the pelvis, and then it comes in the front of thigh, passing through the obturator canal. So root value is the L2, L3, L4. So lumbar plexus is formed inside the psoas major muscle. Then from the large iliac fossa is the muscle taken is the iliacus in the pelvis, and this iliacus tendon also coming below the bridge, that is the inguinal ligament. This tendon accompanied the psoas major muscle and is also inserted over the posterior surface of the lesser trochanter. So its combination called iliopsoas. Then the longest muscle of the human body comes, that is the sartorius, taken from the anterior superior spine and is coming downward and medially and inserted over the upper part of the shaft of the medial surface of the tibia with the inverted hockey shape insertion just lateral to the insertion of gracilis. So this is the sartorius, longest muscle of the body, crossing two joints, hip joint as well as the knee joint. So this is the how sartorius is formed, coming from lateral side and inserting over the medial part. Then there was a quadriceps femoris muscle. This muscle takes origin from the four parts. Lateral part is called vastus lateralis, taking origin from the linea aspera posterior border. Then medially comes vastus medialis, which also takes origin from the posterior border or linea aspera of the femur. Then the anterior surface of the femur gives the origin of the vastus intermedialis. So all these three muscles, they join together in front of the shaft of the femur, and erectus, fourth part, the rectus femoris muscle comes from the anterior inferior spine and is also fused with the already three fused muscles to form a very strong tendon, combined tendon of the four muscles, that is called the quadriceps femoris. And this tendon of the quadriceps femoris is inserted over the tibial tuberosity. And in this tendon there is the sesamoid bone, that is the patella, on the posterior surface, minimizing the friction between the tendon and the lower end of the front of the femur and the anterior surface of the upper end of the tibia. So this is the ligamentum patelli from the apex of patella to the tibial tuberosity. The brown muscle ends over the patella. So these were the, we encounter the 12 muscles. Stepwise, the superfascia, deep fascia. After removing the deep fascia, we see this picture of the front of the thigh. Now, quadriceps femoris muscle is supplied by the femoral nerve. So, femoral nerve is also formed inside the psoas major muscle, but it comes out of the psoas major from the lateral border of the psoas major, and then it also passes below the inguinal ligament to enter into the lower limb, and it supplies the, it also divided into two divisions. Anterior division supplies the sartorius, plus it gives the nerve that is called the saphenous nerve. It's the longest cutaneous nerve. It comes medially below the sartorius on the medial aspect of the knee joint, and then is continued down in the leg medially and ends into the medial part of the skin of the foot. Then this posterior division of the femoral nerve is supplied the quadriceps femoris with all its branches. Nerve to vastus medialis is the thickest out of them. So this is the, what is the femoral nerve. Now muscles, they are very rich in blood supply. So the artery comes to supply these muscles So this artery is the continuation of the external iliac artery. As we have done the abdomen, we know the abdominal aorta, it bifurcates into right and left common iliac artery at the lower border of the L4 vertebra. So lower border of the L4 vertebra is the bifurcation point of the abdominal aorta, terminate or ends here. So at the L4 level, the two branches of the aorta comes. That is called the right and left common iliac artery. So this right common and left common iliac artery divided into two branches. One is called the external iliac artery and one is the internal iliac artery. Internal iliac artery has got the 8 to 9 branches, goes into the various organs in the pelvis, while the external iliac artery goes outside the pelvis and it passes below the bridge, that is the inguinal ligament, like the femoral nerve, and enters into the front of the thigh. Before it enters the thigh, so when it enters into the thigh, it crosses the inguinal ligaments. Its now name changes. Now it is called femoral artery, because now this artery is the property of the lower limb, so it is called the femoral artery. Above the inguinal ligament, its name is external iliac artery, and external iliac artery has got only one branch that we have done in the rectus sheath. So this artery is the in medial relation to the deep inguinal ring, that is called the inferior epigastric. Only one branch, and it is given by the external iliac artery just before it becomes the femoral artery. Then the femoral artery enters into the thigh, front of thigh, and it gives the various branches. Its main branches, they are the right and left circumflex femoral arteries. So these right and left circumflex, they go around the femur. That's why it's called the circumflex. The lateral circumflex femoral artery divided into three branches: ascending, descending, and transverse. Ascending, descending, and transverse. The ascending branch of this lateral circumflex femoral artery runs toward the anterior superior spine, and it supplies various muscles coming in its way. The descending branch, it descends into the quadriceps femoris muscle and supply the quadriceps femoris. And by supplying it, it reaches down into whole of the muscle supplies, and then it reaches up to the patella. And in the patella, it anastomoses with the another artery branches to form the prepatellar arterial anastomosis. Then the medial circumflex, then the third branch is the transverse branch. So transverse branch is horizontal. It goes and skirts around the shaft of the upper part of the femur, and it meets with its fellow, the transverse branch of the medial circumflex femoral artery. So this artery is the medial circumflex femoral artery. So it has got only two branches. One is the transverse branch, which goes around the femur and anastomoses with the transverse branch of the lateral circumflex femoral. Then another branch of it is the ascending branch, which supplies the various muscles in this region. So this is how the two circumflex femoral arteries, they supply the muscles. Then the femoral artery descends downward to supply the another muscles. and posteromedial to this artery, it is a very large artery branch. Posteromedial, it is a very large branch. And this branch of the femoral artery is called the profunda femoris artery. Profunda femoris artery. So profunda femoris artery also supplies the various muscles, and this artery runs posterior to the adductor brevis muscle and adductor longus muscle, and it gives the 4 perforating branches which passes through the osteoaponeurotic openings of the adductor magnus muscle. From these openings, they go to the posterior part of the thigh and supply the muscles of the back of the thigh. Then this profunda femoris artery terminates as the 4th perforating artery and anastomoses with its own artery. It forms an arterial anastomosis on the posterior surface of the adductor magnus muscle and supply the hamstring muscles, that is the muscles of the back of the thigh. After giving these of branches, the femoral artery then passes in the middle one third of the thigh behind the sartorius muscle, and it runs towards the hiatus magnus, and this artery then passes through the hiatus magnus, which is a osteoaponeurotic openings just above the medial condyle of the adductor tubercle, through which this artery, this hiatus magnus, is made for the passage of the femoral artery. So this femoral artery passes through the hiatus magnus and it disappears from the front of the thigh. Before it disappears from the front of the thigh, it gives the last branch. Before it passes to the adductor magnus, this last branch of the femoral artery in front of thigh is called the descending genicular artery. It is called descending genicular artery. And this descending genicular artery, it is continued and accompanied by the saphenous nerve down in the medial part of the thigh. So its branch accompanying the saphenous nerve is called the saphenous artery. And another horizontal branch of this artery is the genicular branch, and this genicular branch anastomoses with the descending branch of the lateral circumflex femoral artery to form the pre-patellar arterial plexus and supply the patella as well as the ligamentum patellae. So this branch is called genicular branch because it is going in front of the, that is called genu, that is the knee or the bend. So it has got 2 branches, saphenous branch and the genicular branch. Both are branches of descending genicular artery. And these 2 arteries, they are also reinforced by the lateral and medial superior genicular arteries, which are the branches of the popliteal artery. So a very good anastomosis is formed anterior to the patella and giving the good arterial supply to the most frequently used and weight-bearing joint of the human body, that is the knee joint. So this is the arterial anastomosis around the knee joint, we can say, seen from the front part. Then wherever the artery goes, vein comes. So artery goes disappear from the front of the thigh through the hiatus magnus and posterior to the knee joint. Now it is called the popliteal artery. Here it touches the popliteal surface of the femur and continues down as the popliteal artery in the popliteal fossa. So from the same popliteal fossa, accompanied by the popliteal artery, comes up is the popliteal vein. And this popliteal vein comes to the hiatus magnus from the popliteal fossa, and it is accompanied the popliteal artery. And this artery runs upward. Now when it comes to the hiatus magnus in front of thigh, now it is called the femoral vein is the name now. Now it is called the femoral vein. And femoral vein runs upward, very, very near to the femoral artery, which is descending. And this femoral vein also receives the profunda femoris vein, which is accompanying femoral artery, profunda femoris artery. Then this femoral vein, lying medial to the femoral artery, reaches the inguinal ligament. Here this femoral vein now passes below the inguinal ligament and it enters into the pelvic cavity. Now its name changes, now it is called the external iliac vein. Now it is called the external iliac vein. Similarly, from the internal iliac artery, internal iliac vein comes. And on the right side, by the combination of the internal iliac vein and the external iliac vein, inferior vena cava is formed on the right side of the abdominal aorta. Similarly, same thing is happening on the right side, left side also. So the inferior vena cava is formed by the combination of the left external iliac and left internal iliac veins also. So then the common iliac vein and the right and left common iliac veins, they unite to form inferior vena cava formation in the pelvis on the right side of the L4 vertebra, where the aorta terminates, inferior vena cava started. Now, as the blood vessels, they are coming from the abdomen into the front of the thigh, so they drag with them two layers. One is the fascia transversalis and another is the iliac or fascia iliaca. And the upper 3 centimeter of the blood vessels, that is the femoral artery and the vein, they are covered by this two fascia, iliac fascia posteriorly and anteriorly fascia transversalis. So a sheath is covering the upper 3 centimeter of the femoral artery and femoral vein. So this covering is called the femoral sheath. Femoral sheath is the name given. Only upper 3 centimeter. Femoral nerve is not inside the sheath. Underline. The femoral nerve lies outside the femoral sheath. Only femoral vein medially and femoral artery laterally, they are wrapped by a sellotape-like structure that is called the femoral sheath, whose anterior wall is derived from the fascia transversalis and posterior wall is formed by the fascia iliaca. Same fascia which is covering the iliacus muscle is becoming the posterior wall. So you have to remember this structure is this is fixed. Femoral vein is medial, femoral artery is in the middle, and femoral nerve is lateral in position. So this is the formula. V, A and vein relation you have to remember. Vein is always medial, then artery, and N is the nerve. So vein relationship is there, same as we have done in the intercostal spaces also. So there was also the intercostal vein, artery, and that was the vein relation. Another vein is here in the front of the thigh. Now when we closely see the femoral sheath, it encircled posteriorly by the fascia and anteriorly it is formed by the fascia transversalis, and it is wrapping the two vessels, big vessels supplying the front of the thigh structures. So this femoral sheath internally is divided into two compartments by the septa. So these septa, they are dividing the femoral sheath internally into three compartments by two septa. So one is the medial septum, other is the lateral septum. The lateral compartment is called the arterial compartment because it contains the femoral artery. The middle or intermediate compartment is called the venous compartment because it contains femoral vein. The medial compartment is empty. It is only having one single structure, that is the single deep inguinal lymph node. Deep inguinal lymph node. And this medial compartment of the femoral sheath is called the femoral canal. The medial compartment is called the femoral canal. So if I put my finger from the below, just medial to the femoral vein, my finger can go into the abdominal or pelvic cavity. Because this canal means a pipe. So it is open superiorly to the abdominal cavity, inferiorly it is opened in the lower limb or the front of the thigh. So this medialmost compartment, just lateral to the venous compartment. So this upper part of the femoral canal, which is facing towards the abdomen, is having a ring-like structure. This ring is formed. So the boundaries of this upper part of the femoral canal is called the femoral ring. The lateral boundary of the femoral ring is formed by the medial septum of the femoral sheath. The medial septum of the femoral sheath. The medial boundary of this ring, this one, is formed by the lacunar ligament. Lacunar ligament. And this posterior boundary of the femoral ring is formed by the pectineal ligament. Pectineal ligament. So if I put my finger into the femoral canal, the nail of my finger will touch the pectineal ligament, the posterior. The lateral border of my finger will touch the medial intermuscular venous compartment, septum, medial septum. Medial border of my finger will touch the lacunar ligament. And this ball of my finger will touch the inguinal ligament. So this is how you have to remember the boundaries of the femoral ring. As we know, the lacunar ligament is the lateral extension of the inguinal ligament. When the inguinal ligament is attached to the pubic tubercle, a few fibers of the inguinal ligaments comes laterally, and these ligamentous or aponeuritic fibers of external oblique lateral to the pubic tubercle, they are attached to the pectineal line. So they are called the pectineal ligament, and from where they bend. So this is the pectineal ligament, this is the inguinal ligament. So where they bend, they form the moon shape, that is called the lacunar ligament. So lacunar ligament is also the lateral continuation of the apneutic fibers of the inguinal ligament we have done in the abdomen already. So this ring is small form. So this ring is called the femoral ring. So this is the upper 3 centimeter of it. And it contains a single lymph node, which is a deep inguinal lymph node. The name of this lymph node is the Cloquet's lymph node. Cloquet's lymph node, or it is also called the lymph node of Rosenmuller. Rosenmuller lymph node or Cloquet's lymph node. So it is a deep inguinal lymph node, and a single lymph node is present in the femoral canal, the content. And this deep inguinal lymph node drains the glans penis in the male and the tip of the clitoris in the female. So this is the area drained by the deep inguinal lymph node, the Cloquet lymph node. Now this femoral ring, which is present on the upper part of the femoral canal, is the site for the femoral hernia. Because as my finger can go from the thigh into the abdomen through this canal, then anything from the abdomen can gravitate inside it. So that leads to what is called the femoral hernia, and this femoral hernia is very, very common in the females. So remember F for F, femoral canal, femoral hernia is in the female. So why it is common in the female? So there are certain causes. Number one cause in the female is the blood vessels, they are in small size. Femoral vein and femoral artery, their lumen or their diameter is lesser than the male, because the male has got the more muscles, more muscular work they do. So the muscles of the thigh, they are more stronger and bigger than the female thigh. So a big artery supplies the male muscles, so it becomes dilated. In the female, it is less dilated, so the vessel becomes smaller and the compartment, the femoral ring will become bigger. So that's it. Second reason in the female is because of the multiple pregnancies. So because of the multiple pregnancy or multigravida, so every time the abdomen is stretched and again it goes back. So more pregnancy will weaken the lower abdominal muscles, or anti-abdominal wall is weakened, that precipitate in the formation of the femoral hernia. So that is the two most reasons for this. Then the female, they are more engaged in their household work and they remain standing in position. So again, because of the prolonged standing, the gravity counts and that lead to the hernia also. Or other, in the female who are engaged in some work in factories where prolonged standing is there for 6 hours or 8 hours duty, so these females, they are also prone to the femoral hernia. So whenever there is a femoral hernia is there, so the female or the patient comes with the swelling in the upper medial part of the thigh, just below the inguinal ligament. So patient comes with the complaint of this swelling just below the medial part of thigh, which lies just below and lateral to the pubic tubercle. And like inguinal hernia, it may be reversible or irreversible. And also the same causes also depending upon the content. It may be omentocele, if greater omentum comes from the abdomen into the hernia. It is called enterocele, when some loop of the jejunum ileum comes. It is called vesicocele, if the urinary bladder comes into the hernia, because urinary bladder lies just behind the pubic symphysis. There are chances that the and the wall of the urinary bladder comes out. So varicocele, the vesicocele, enterocele, and the omentocele are the names given. Same we have done already in the inguinal hernia also. Now what is the treatment? So in the treatment of the femoral hernia, we push the contents along with the peritoneal sac which is coming out of the femoral canal. So this is the femoral canal, and this sac comes as the hernia, which is peritoneal sac, and it may contain any loop of the jejunum and the ileum coming from the abdomen, or the part of the lower body of the greater omentum. So we have to push the peritoneal sac along with the content back into the abdomen. But as the femoral ring is small, so we have to widen it, as we have already done in the inguinal hernia also. So first step of this surgery or in the hernia is the herniotomy. Herniotomy means to make a hole. Otomy means a opening. A opening is widened for the pushing of the sac along with the contents back into the abdominal cavity. First step is called the herniotomy. So here we have to widen the femoral ring. So in order to widen the femoral ring, we have to cut certain structures so that we can push the large gravity prone content of the peritoneal sac and with contents in. So this the femoral ring is there. The boundary is superiorly by the inguinal ligament, posteriorly by the pectineal ligament, and medially by the lacunar ligament. We can't widen it laterally because here is the venous, that is the femoral vein is there. So we may cut and bleeding may be there. We cannot widen by cutting the pectineal ligament because it attaches to the pectineal line or the pecten pubis. The bone is there. You can't cut the bone. Anteriorly, superiorly, it is bounded by the inguinal ligament. We can't cut the inguinal ligament to widen the ring. Only thing we have to widen is we have to cut the lacunar ligament. So we cut the lacunar ligament because there is no artery, no vein, no nerve is there, and we can widen it up to the pubic tubercle. So in the herniotomy, we cut the lacunar ligament to widen the femoral ring, but here sometime a problem comes. Sometimes the obturator artery, which is the branch of the internal iliac artery, passes to the femoral obturator canal accompanied by the obturator nerve. Usually it passes below the inguinal ligament and through the obturator canal, then enters the front of sac. But sometimes it passes medial to the lacunar ligament. So it passes the femoral canal, and then from the femoral canal it enters the medial compartment of the thigh. So this is the abnormal course of the obturator. So course of the obturator artery is abnormal in some of the people. So surgeons should be cautious while cutting the lacunar ligament that there may be an artery, and he or she may cut it and that lead to the bleeding. Otherwise, the lacunar ligament cutting for herniotomy is the safe. But here comes the problem. Same we have also done in the inguinal hernia. That is there was a superficial inguinal ring in the inguinal hernia. So again the hernia comes to the superficial ring, a big sac of the peritoneal is there, we have to push it back. So there was a herniotomy was the first step of the surgeon do. We have to widen this superficial inguinal ring so that whole of the swelling can go. So here what we cut, the apex of this ring. So we can cut this ring as much as possible. So it is possible. So there is no artery, no vein, no nerve is there. So that is also the herniotomy. So we widen the superficial inguinal ring and then we push whole of the sac of the peritoneum along with the contents. And after that, after pushing everything, then what we do, we stitch the apex of the superficial ring. Only that much that it allows the passage of the round ligament of the uterus or the spermatic cord. So we repair it. After cutting and widening and pushing the sac, we again close the superficial inguinal ring, but now we only leave the small hole for the passage of the spermatic cord or round ligament. So this is again a procedure. This surgical procedure is called the herniotomy. The second step done by both the hernia is called the herniotomy. So whenever a question comes of the hernia, in the treatment part you have to write down in both the inguinal hernia as well as the femoral hernia, the herniotomy, what is to be done, and herniotomy, that how to restitch the widened cutting structures of superficial inguinal ring in the case of the inguinal hernia. And in the femoral hernia, what we do after cutting the lacunar ligament, then what we do, the inguinal ligament is stitched with the pectineal ligament. So inguinal ligament is forming the anterior boundary and pectineal ligament is forming the posterior boundary. So what we do, we approximate them, we make them closer and we stitch it. Or in otherwise, and we also cut the, we also stitch the lacunar ligament. So what in the other words, we are closing the femoral ring. We are closing the femoral ring because there is no structure is passing like the spermatic cord or round ligament as in the inguinal hernia. So we can close the femoral ring after the operation. So that is the major step done by the surgeons. The herniotomy, herniotomy, that is the repair of the femoral ring is called the herniotomy. So that is how you have to attempt the question when comes the femoral canal with its boundaries and the contents and the applied. One is called the hernia and another is the cancer of the glans penis or cancer of the cloacaed lip or the tip of the clitoris. So whenever a case of the cancer of the glans penis in the male and the tip of the clitoris comes, what we do in this case is, if there is a cancer of the glans penis is there, it means the growth is there. Cancer is a unlimited, unwanted growth of the any tissue of the body. So the glans penis is enlarged because of the growth. Or in the female, the tip of the clitoris is having the cancerous growth. So what is the treatment the surgeon do? We cut the glans penis along with the growth. Or in the female, we cut the tip of the clitoris along with the growth. This is the first step done by the surgeon. Number 2 step is very, very important for a surgeon. A surgeon should not forget to remove the single cloacaed lymph node lying in the femoral canal. If a surgeon fails to remove the cloacaed lymph node, then after 6 months the cancer will spread to the whole of the human body and patient will die. Because the cancer cells from the glans penis, they have already gone into the cloacaed lymph node. And from the cloacaed lymph node, these lymph nodes, they are travel into the lymphatics, they are interconnected. And these lymphatics from the cloacaed lymph node, coming from the glans penis or tip of the clitoris, already draining it, they go into the lymph nodes around the aorta or in front of the bifurcation of the aorta. So the lymphatics of the cloacaed lymph node is already interconnected. So the cancer cells from the growth, they have traveled and they are present into the cloacaed lymph node. From this lymph node, the cancer cells, they can go inside the abdominal cavity through the pre-aortic and para-aortic lymph nodes. The lymph nodes present in front of the bifurcation aorta, they are called pre-aortic lymph nodes, and parallel on the side of the lymph nodes in the aorta, they are called the para-aortic. So a single lymph node removal can prevent the spread of cancer to these aortic lymph nodes. So that is the clinical importance. So two things you have to cover whenever a question of the femoral canal comes. The two applied, one is the crooked lymph node cancer of the glans penis and second is the femoral hernia. So this is how we have to do the applied anatomy related to the femoral canal. Another thing in the front of the thigh is the femoral triangle and adductor canal. So femoral hernia is nothing, femoral triangle is nothing but it is a triangular area who is bound by the various muscles in this region. So a triangle is formed in front of thigh after removal of the skin, superfascia and deep fascia, which form the roof of the femoral triangle. So this is the apex of the triangle and this is the base of the triangle. So three angles are there. The medial boundary of the femoral triangle is formed by the adductor longus lateral border. The lateral boundary of the femoral triangle is formed by the medial border of the sartorius. The base is formed by the inguinal ligament. If you know this picture in your mind at how all the muscles we have done and what are the artery veins are present, you can answer any part of the femoral triangle boundary. Medial boundary, lateral boundary, apex and base. So the apex of the femoral triangle is formed by the joining of the lateral border of the adductor longus and medial border of the sartorius here. This point is called the Hunter's point. The apex of femoral triangle is called Hunter's point. Hunter's point. Hunter is the name of the scientist who discovered it. Hunter's point. Hunter's point is very, very important clinically because the injury at the Hunter's point, at the apex of the femoral triangle, lead to the death of a person. Any knife or the bullet injury or accidental injury which is piercing the apex of the femoral triangle will damage the four vessels. You know, all four vessels they gather near the apex. Number one is femoral artery. Number two is the profunda femoris artery. Number three is the femoral vein. And fourth is the profunda femoris vein. So four vessels, two big and two smalls, may be cut. This lead to the profuse bleeding and patient may die on the roadside accident lying in the pool of blood. So that is the clinical importance of the apex of the applied of the femoral triangle. So whenever a question comes, first we have found the roof of the femoral triangle formed by the skin, superfascia and deep fascia. Then come the contents, boundaries, apex and base and lateral and medial wall. Then come the contents. So whatever you see in this triangle are the contents. So what is the content? Number one, medial to lateral. Medial is the femoral canal. Then femoral sheath containing femoral vein and femoral artery. They are the contents. Then femoral nerve along with anterior and posterior divisions. So these are the contents and the branches of the femoral artery. The lateral and medial circumflex femoral. So they are also the contents. So if you know this picture in your mind, you made it, you can answer any part of the femoral triangle. Roof, boundaries, the contents. When I lift the femoral artery and veins upward, what lying behind these vessels and the nerve is called the floor of the femoral triangle. Floor. So when I lift, who is forming the floor? From medial to lateral. Number one is formed by adductor brevis, then pectineus, then psoas major, then iliacus. Muscles. So whatever muscles they are present posterior to these vessels or the contents of femoral triangle, they form the floor. So this is how you have to do the floor. So pectineus muscle we have done is the quadrilateral muscle and its lateral half is supplied by the femoral nerve branch which passes behind the femoral sheath and medial half is supplied by the obturator nerve. So this muscle enjoys the two nerve supply. Medial half by the obturator nerve and lateral half by the femoral nerve, because it lies in between the two nerves. So such a muscle is called the hybrid muscle, or a muscle with the dual nerve supply. So that is all about the femoral triangle. Applied is the Hunter's point, and another applied is that whenever we require the arterial blood for testing, we collect from the femoral artery safely, because in a patient who is in the coma, arterial pulsations, they are very weak, but femoral artery pulsations, they are quite big. So we can put a finger over the lower part of the inguinal ligament or inguinal crease of the patient here, and we feel the pulsation. And with the one finger we are feeling the pulsation, with the another hand we put the needle of the syringe, and we can collect the arterial blood very safely. In that same coma patients, if you want the venous blood collection, because all the veins in the periphery, they are collapsed, they are not visible in the coma patient. So we just put the finger on the femoral artery just below the inguinal ligament, which is a very tight and hard ligament here, and we feel the pulsation, and we just put the needle of the syringe just medial to the femoral artery pulsation. Then we can draw safely the venous blood. So sometimes we want arterial blood for the testing of the patient disease, or venous blood is most frequently the, because we know there is a very relation that just medial to the femoral artery there will be a big artery vein, that is the femoral vein, and thickness of the femoral is a little more than your little finger. So it's quite big vein. So safely we can, so that is also comes under the applied anatomy of the femoral triangle, because they are the artery and vein, they are the contents of the femoral triangle. Then another thing in the front of thigh is the adductors or the Hunter's canal. Adductor canal or Hunter's canal. Actually, adductor canal and Hunter's canal, they lie in the intermuscular space. It is the intermuscular space, and where it lies? Just in the middle 1/3 of the medial part of thigh here. So this area is called the adductor canal. Middle 1/3. So thigh is divided into upper 1/3, middle 1/3, and lower 1/3. So in the middle 1/3 it lies the adductor canal. So it is intermuscular space. The boundary is laterally formed by the vastus medialis. Vastus medialis muscle we have done, and the medial boundary is formed by the adductor longus muscle. This was the adductor longus. The medial boundary is formed by the adductor longus muscle, lateral one the vastus medialis. So it is a triangular space between the two muscles. Because quadriceps femoris, vastus medialis is higher in position. The adductor muscles which are come medially, they are in lower position. So one is higher up, this is lower one. So a space is created between the two muscles. So that is called the adductor canal. And this adductor canal extends, it starts superiorly from the apex of the femoral triangle. Apex of the femoral triangle is the start of the adductor canal, and where it ends, hiatus magnus. So from this point to this point is called the adductor canal. Why it is called adductor? Because it lies in the adductor longus muscle, forming the medial boundary. And so they are the boundaries. Then contents. In the contents, two arteries, two veins are the contents. Sorry, two vessels and two nerves. Two vessels, they are number one, femoral artery and femoral vein. They are the two vessels of the content. And two nerves. One is the saphenous nerve, and another nerve is the nerve to vastus medialis. Nerve to vastus medialis. So they are the two nerves and two vessels. You have to remember, you have to write down. Profunda femoris artery and vein, they are not the content because they lie behind the adductor longus. They are not the content. Only two vessels and two nerves are there. Then the floor, the roof. So roof of this adductor canal is formed by the skin, then superficial fascia, and just below the supral fascia there is a aponeurotic roof. Aponeurotic roof is formed by the union of the muscular sheath of the adductor longus and vastus medialis. We know all the muscles, they are covered by a thin sheath that is called the muscular sheath. All muscles, they are separated from each other. So the sheath which is covering the adductor longus muscle and sheath which is covering the vastus medialis muscle. So both the sheath or the coverings of these two muscles, they are joined by a aponeurosis. And that forms the roof of the adductor canal, and this roof of the adductor canal contains subsartorial nervous plexus. And above this roof lies one is the skin, then superficial fascia, and below the superficial fascia is the deep fascia. The fascia lata forms the roof, and the fourth thing forming the roof is the sartorius muscle. Sartorius muscle from the roof, and just below the sartorius, the sheath of the adductor longus and the vastus medialis, they join, and they form the aponeurotic roof. And in this aponeurotic roof, below this sartorius, forms a plexus by two nerves joining. So these nerves, they are the branches of the obturator nerve and femoral nerve, and they form the subsartorial nervous plexus. So this is how we have to do. So roof is formed by the sartorius muscle, and medial boundary is formed by the adductor longus muscle, lateral boundary formed by the vastus medialis. So this intermuscular space is called the adductor canal. Laterally in the content is the femoral artery, medially the femoral vein, and near the roof there lies the saphenous nerve, which is crossing from lateral to medial side, and then nerve to vastus medial. So this is how you have to form the diagram of what is the subsartorial canal. So then the sheath which is covering the adductor longus and covering the vastus medialis, both are joined just below the sartorius. So this is the aponeurotic roof. And this aponeurotic roof lies the nervous plexus by the branches of the saphenous nerve, and another branch comes from the medial cutaneous nerve of the thigh, which is the branch of the obturator nerve. So these two nerves, they contribute in the formation of the subsartorial nervous plexus. So this is how we do the adductor canal or the hunter's canal. Now come the applied knot. Applied knot with the adductor canal is that this canal is very optimal or appropriate site for the ligation of femoral vessels. So femoral vessels can be safely ligated in any cut or crush injuries of the leg and the foot, or any operation done on the aneurysm of the popliteal artery. So whenever this if some accident occurs and a leg, on the leg and the foot, some vehicle has gone, and there is a crush injury of the leg and foot, so all the vessels, they are profusely bleeding. So in order to stop the bleeding, we cannot expose the femoral tank. Ligation in the femoral tank is not possible because here are so many vessels are there. So that hunter's point may be there, you may cut them. But this is very easy to open because the roof of the adductor canal is formed by the skin, and below the skin comes the superficial fascia, that is the yellow color fat. Then it is formed by the fascia lata or the deep fascia, and only sartorius muscle is there. So when we cut the skin, superficial fascia and the deep fascia, and we lift the medial border of the sartorius and we just reflect it laterally. And when we reflect it laterally, then apodontic roof is there in front of us. When we remove the sartorius is reflected laterally like this, then we cut the apodontic roof and we reach into the adductor canal. Here two vessels, they are lying very, very parallel, femoral artery and vein. We just take a thread and we make a knot. This is called the ligation of the vessel. So immediately when we ligate the vessels, bleeding is stopped. And patient can be immediately shifted safely without bleeding to the operation table in the nearby hospital. So that is the applied anatomy related. So this is very important side. No injury is possible here. And we can expose safely the two vessels that are visible in front of it. So this procedure has been given training to the army people. That whenever in the war field, if some bullet injury occurs to the leg or the foot and bleeding is there, how to shift the patient from the battlefield to the military hospital, so they know what is the adductor canal. They know how to ligate. So it is just patient is lying, so you take anything in your hand, or a knife or something is there, or just a small piece of wire, you can cut the skin in the middle 1/3 of the thigh. You can remove the skin, you can remove the superfascia, deep fascia, and you directly see the two vessels are lying. So you can take thread from here and there and just ligate, and patient can be safely shifted. So this training is already given to the army people. Another training is given how to hit the bullet into the hunter's point, to the enemy. So they know where to hit, because they know where is the hunter's point. And when the enemy is injured at the hunter's point, there may be bleeding, he may die. So this is the all army people know what is the adductor canal, what is femoral triangle, and what is the femoral apex and hunter's point. So that's all we should know about the front of the thigh. Systematically going from the skin deep up to the muscles and the